Hello, those of you that are joining our webinar. We're going to take about a minute of time to let people come in. We had 98 people register for this webinar last time I checked, so that is so good. If you want, you can go ahead and put where you are joining us from in the chat. We always love to hear that. I'm actually broadcasting from TMA office in Columbia, Maryland, and oh, we've got Toronto, Canada. Yay. I saw Connecticut. All right. Oh, there's another Canada, Ohio, New Jersey. Well, welcome one and all. Hello and welcome to the Myositis Association's Ask the Doc webinar series. I am broadcasting from the TMA office in Columbia, Maryland. As I said, please let us know in the chat box where you are tuning in from. Our last webinar, we had Croatia and China represented, along with the UK and Turkey also, I believe. So it's always so exciting to see people from all sorts of states and countries. So please let us know. TMA's Ask the Doc webinar series features a member of TMA's Medical Advisory Board or another distinguished member of the myositis medical community. And today we have not one, but two of them. As someone who lives with myositis, whether as a patient or care partner, you may have many questions about the condition, medications, and how to navigate the healthcare system. Perhaps your local care team has a limited understanding of myositis and how to treat it. This series offers you the valuable opportunity to have your questions addressed by a knowledgeable expert. It is also a way that you can educate your community about these conditions when you share information learned during this session with your care team, family, and friends. My name is Rachel Bromley, and I am TMA's Senior Manager of Patient Education, Support, and Advocacy. Before we get started, some housekeeping notes. This webinar is being recorded and will be available on TMA's YouTube channel on the 1st of next month. You can just search for the Myositis Association on YouTube and you'll find us. And if you subscribe, you can allow for notifications so you can get a notice anytime we drop a new video. So today, we have the honor of speaking with, as I said, not one, but two experts. Eleni Tiniakou is an assistant professor of medicine and rheumatology at the Johns Hopkins Myositis Center. Her research focuses on identifying and describing specific T cells in myositis and scleroderma and how these relate to cancer. Jun Kang is an assistant professor of dermatology for the Johns Hopkins Outpatient Center, as well as the director of Cutaneous Autoimmune Connective Tissue Disease Program, where he specializes in treating patients with dermatomyositis, cutaneous lupus, and other dermatologic manifestations of rheumatologic disease. Additionally, he has a database and tissue bank and conducts research on dermatologic manifestations of DM and lupus. And I am glad that the biography portion is over because it's always a nail biter if I'm going to be able to pronounce everything. Thank you both for being here today for Ask the Doc DM edition.
Hi, everyone. It's a pleasure to be here.
Thank you so much for having me tonight.
Yes, great. All right. Well, any questions you have, please put them in the Q&A box and we will get started. I've got you spotlighted. Okay. All right, so why don't we start off with something very basic? Can you just outline for us dermatomyositis, what it is, how it's diagnosed, and what people can expect when they have this disease?
I can start from my rheumatologic standpoint. So there are many different definitions for dermatomyositis. It is an autoimmune disease, which means our immune system, which is there to protect us from infections and cancer and everything else, gets confused and it starts attacking our own cells. In the case of dermatomyositis, it can attack the skin, the muscles, the lungs, the joints. So it can be a multi-systemic disease. The first definition of dermatomyositis is a patient having muscle disease and additionally skin manifestations. Although now we know that this is not complete, and we have patients with only skin disease or some mild muscle involvement. And then another definition of dermatomyositis that we're now starting to use is based on autoantibodies. So even if the patient does not have skin manifestations, the typical ones that we see in dermatomyositis, if they have an autoantibody that we are associating with dermatomyositis, we might still call them dermatomyositis.
Dr. Kang, did you have anything to add to that?
I think Dr. Tiniakou summarized that beautifully. I think the skin manifestations as a dermatologist who see patients suffering from these conditions can be quite diverse. And that's really true also with just clinical heterogeneity of this condition, I think. So it is a challenging disease to diagnose, I think, correctly. And from the skin perspective, it can often be misdiagnosed with other autoimmune conditions like lupus and even other more skin-limited conditions that we have seen over the years. So.
Okay, is it common to see folks suffering from autonomic dysregularities in DM? Do immunosuppressants help with the symptoms, or do you typically add some other medication on for the autonomic issues?
Autonomic, you mean autonomic nervous system or autoimmune?
I would guess that they mean autoimmune since they are talking about immunosuppressants, but I'm not sure. They can add more information in the Q&A if they want.
So because there is also, it can be an autonomic dysautonomia component in dermatomyositis like POTS, which can complicate things, but that is a separate issue. But it is autoimmune, and we do treat it commonly with immunosuppressant medications. We want to suppress the immune system so that it stops attacking our own cells. But in dermatology, they have some different options as well.
Absolutely. I think if the I'm not sure the question was specifically regarding like autonomic dysfunction, maybe is that the question was, which sometimes we do see in some of our patients who often present sometimes with similar skin manifestations actually. So people that have things like mast cell syndrome can often get flushing of the face and things like that. And I've certainly seen patients who may have dermatomyositis, but also some neurologic manifestations where the skin is flushing easily. People get conditions like erythromelalgia, which I think of it as a kind of autonomic dysfunction in a spectrum of the condition where two conditions are occurring concurrently. And to answer the question further, in terms of immunosuppressive agents that we use to treat dermatomyositis, those conditions don't always get better, unfortunately, and that can be quite challenging to treat for some of our patients.
When this person first started taking IVIG treatment, they had horrible headaches and neck pain. Will this go away with more fluids being pushed? Will it eventually even out? What are your thoughts on this particular side effect from IVIG?
So in order to, we use IVIG a lot, and we do, the most common side effect are headaches. The way to try to deal with this is pre-medication, drinking a lot of fluids the days before the IVIG, having Tylenol before you get IVIG, and then slowing the rate of IVIG if needed, which means you can divide the IVIG into within more days, so that it can be given slower. That can decrease headaches. And if these things don't work, another way is to divide the dose and give it every 2 weeks, which means you get a smaller amount of IVIG, but in the end, within a month, you get the same amount. And finally, another option is to transition to subcutaneous IG, which has less side effects, but that depends on the insurance.
And so before we get too focused on IVIG, can you just talk about treatment options in general?
I can start with this one. So I think the treatment armamentarium really varies depending on what type of organ disease you have involved. So as we already alluded to, it is a systemic autoimmune disease, but not every patient will manifest with every part of that disease. Some patients, unfortunately, do have a lot of those. For example, if they have ILD, that's going to really lead the treatment strategy that you have. But sometimes you have amyopathic patients, so who don't have any muscle disease, who might only present with skin symptoms without, say, a ton of lung involvement, joint involvement, and things like that. So when I see patients with a more of a milder phenotype who present predominantly with the skin, I'll probably try to use things that are less immunosuppressive in hopes of controlling their symptoms. So it really depends on the manifestation of the disease the patient has, and also underlying health disease as well. As you know, dermatomyositis can be associated with cancer. So if they have cancer, that's something that we really want to treat. We want to avoid, T cell immunosuppression that can really, increase the risk of cancer progression and things like that. So.
Thank you. Can one find a high CD4/CD8 ratio in a BAL during bronchoscopy and DM?
So first of all, we don't do much BAL anymore. So this is based on older studies. They have found, as far as I know, both CD4 and CD8 T cells. And then it depends on the study. If someone is focusing on CD8s, I think they would focus on CD8s. And these are more of the studies that I've seen, more CD8 T cells in the lungs. But based on what I know.
Okay. This person has liver toxicity with MMF and is being switched to IVIG. Would you recommend IVIG combined with Rituxan?
I think this is, I think treatment-wise, I think there is no right or wrong answer, is what works for the patient. IVIG is usually with good results. So personally, I would start with IVIG, and then for maybe 2-3 months, and if this is not enough to treat the disease, then I could add rituximab.
Okay. What research data is available to describe DM progression without ILD in patients who opt out of receiving treatment?
The question is, patients without ILD, if patients opt out of treatment, what are the risks of progression? I don't know of any specific data that has robust information on kind of monitoring of the disease without treating it, because I would say generally we typically intervene in patients with dermatomyositis, even if they don't have ILD. I would say with the skin disease, again, if patients initially present with skin disease, whether they will develop muscle disease or not, that can certainly vary. So we typically give them a provisional diagnosis of amyopathic dermatomyositis if they haven't developed any muscle symptoms within the first 6 months. But we're talking about patients who haven't received, a significant amount of immunosuppression already, because medications that we use will also may change the trajectory of that disease course as well. But I don't know that we have a ton of data on seeing the natural course and what are the progression of the disease without any intervention. Maybe Dr. Tiniakou does.
No, I don't think there are any data. When someone, though, has muscle disease, I always push for treatment. Of course, it's in the end, the patient decides. But I'm worried with the muscle disease that it will get worse, and then the side effects, the consequences will be more severe, because then the patient can, that can lead to muscle atrophy, which means you cannot get that muscle back. So when there is muscle involvement, I definitely recommend treatment. If there is only skin disease, I don't think we know what it means to let the skin disease go on. On the one hand, it would mean that maybe we are prepping the ground for a more resistant disease later on because we let it go. On the other hand, maybe nothing happens and we just immunosuppress the patient with the risks of immunosuppression for no reason. But I don't know. That's like a very good question, but I don't think we have the answer.
This person has scarring at the tops of their lungs, along with some nodules and mild bronchiectasis. Is this something you see as a form of ILD in DM?
So we don't commonly see the upper, the upper part of the lung. If we see that, we might think of something else, like for example TB. It's usually at the bases and then it goes up and up. So then I would definitely follow up with a pulmonologist to rule out other causes.
What is your experience with skin issues of the scalp and DM? For example, can it be misdiagnosed as psoriasis when it's part of DM manifestation?
Yeah, I mean, absolutely. That's something that I think most experts who treat patients with dermatomyositis are very well aware of. That one of the clinical presentations of scalp involvement is often misdiagnosed as psoriasis.
I think that's the best time to work with a dermatologist to help with the diagnosis.
Lots of skin biopsies, and everything needs to be kind of interpreted in the context of everything else that's going on. So really, you really want to get a full skin check from the dermatologist to make sure you're not showing other signs of skin manifestations. But again, when it is mild early in the disease, when even skin biopsies aren't always really helpful. And Dr. Tiniakou and I recently just completed a study showing that even patients who do have dermatomyositis, when you do a skin biopsy, even that may not show the typical features of dermatomyositis. So.
This person is newly diagnosed. They started with steroids and methotrexate, waiting on insurance to approve Rituxan. Is the therapy course recommended? They're having insomnia, exhaustion, balance issues, and weakness, especially in hands. And I know you don't know everything in this person's chart. Do you have any recommendations?
All of these medications, except IVIG and steroids, they take at least 4 weeks to show some effect, and at 3 months we would be able to tell if they're working or not. So it's if they're starting the treatment, I think it's hard to tell. And then, are these side effects from the medications, or the patient are these symptoms?
It is symptoms that they are having.
But if they are getting worse, and then definitely they should talk to the rheumatologist or the doctor to, again, steroids and IVIG are the only ones that act very fast. So they might need IVIG.
This person has nodular regenerative hyperplasia of the liver. It is thought that this might be part of their dysautonomia. Have you seen this? Does the NRH get better with immunosuppressant treatment in this case?
I have not seen it.
I'm not familiar with that either.
Seen autoimmune hepatitis, but not.
Okay. What research data is available on effectiveness of alternative treatment options, such as nutritional or environmental changes?
I think the data are limited. There is evidence mostly from mouse models that what we eat changes our microbiome, and that can affect our immune system, but we don't have much data from humans. And also there are case reports and case series of different over-the-counter substances like spirulina that they're thought to trigger dermatomyositis. Again, not proven, these are just what is described.
Okay, this is back to an IVIG question. Do you see IVIG working for a few months when it is new to the body and then reaching a plateau in terms of inflammation in skins and muscles, or it just not working anymore?
Sometimes patients require multiple therapies, and it's not uncommon for us to see that. So we'll hear a lot of patients, letting us know that immediately after getting their IVIG, the first week, the first 2 weeks, they feel great. Their symptoms are improved, they're less itchy, they have more energy, and then that plateaus up. So that definitely does occur in some of our patients. I don't know that if we know for sure why that happens. I think one easy way to answer that is that IVIG, while it is a great medication that works well for our myositis patients, we know that patients don't always respond, and that's going to be true for every treatment they give. So everything kind of needs to be still personalized, and depending on what type of disease that they have and how they're responding, you will need to work with your rheumatologist, dermatologist, pulmonologist to find the right cocktail of medications to really control your symptoms so you can get back to your normal quality of life.
How long do you think it takes? I'm sure it's variable for people to get back to their quality of life. And by that, are you referring to remission, and what does that look like?
Dr. Tiniakou, you want to answer that question? I think you've done some work in this. So.
It's variable that unfortunately we cannot predict. Our goal is always to take the patient back to their baseline, to alleviate any symptom of dermatomyositis with different, as Dr. Kang said, like different combinations of medications. We have limited data from looking retrospectively in patients from our cohort. It depends on the autoantibody. From work we've done with few autoantibodies, usually it's about 1 in 5 will be able to get off medications after like 3 to 5 years. But we don't have a way to predict. But our goal is always to get the patient back to their baseline.
Unfortunately, even those patients who have skin-limited disease, similar to that I've shown, where even after 3-4 years of therapy, a lot of patients still remain on medication. So, IVIG, it takes a lot of toll on our patients. Sometimes it takes time consuming, it's especially if we're having to kind of spread the medications over multiple days. It can really take some time for the patients. But again, our goal is to really try to get back to as high quality of life, as normal as possible for the patients. So.
Okay, go ahead.
One advice that one of my old attendings is giving to the patients is day by day. Do not think so much about the future because it's overwhelming, just day by day.
Oh, that is excellent advice for anyone. This person's taking mycophenolate and also prednisone and receiving IVIG. Their skin symptoms have resolved, but they still have mild muscle weakness. Does the muscle weakness ever completely resolve? And how long is IVIG prescribed?
Usually, most of the patients I see, it's usually the skin that is more resistant. So it is a little bit surprising that everything has gone away, the muscle continues. That means, and if the patient is still on prednisone, the goal is to taper completely the prednisone because it has many side effects. So it means mycophenolate and IVIG are not enough. Either need to add something or switch something. And as Dr. Kang said before, like IVIG, we can have patients for years. There is no limit.
This person has DM and recently tested positive by OMRF for the anti-PM SCL 100 auto antibody, indicating a scleroderma DM overlap disease. What treatments are best for skin and connective tissue that have not improved with methotrexate and now Celsip?
I think this is again, without knowing the full history and really examining the patient, I don't think it's really easy to answer this question, to be honest. You can have PM scleroderma autoantibody and have predominantly, DM phenotype without truly having scleroderma. So it really needs to be worked up fully, entirely. Probably in this case, I would say rheumatologist to really see what features of the disease that the patient is having. In terms of treatment best for skin and connective tissue disease that have not improved with, again, this really comes down to, again, what conditions are we actually treating? Is it actually DM, scleroderma overlap? Do you have a lung disease? So it will really vary, I think, depending. But generally speaking, if you're talking about the skin, CellCept and methotrexate are probably two of the most common medications that we give for skin disease. And IVIG is also very commonly used for refractory disease as well. So.
The only thing, from a rheumatologic standpoint, we tend to avoid using steroids because of the overlap with scleroderma, and that can lead, that's associated with increased risk for renal crisis. So that's the only thing from a rheumatologic standpoint.
This person is newly diagnosed with DM. How concerned should they be about an incorrect diagnosis with high positive NXP2 antibodies, negative skin biopsies, normal CK, positive MRI in calves, weakness, pain, loss of mobility in legs? How common is a false positive panel, and is a diagnosis without perfect labs okay?
I think it depends which lab did the testing. Each lab has different sensitivity and specificity. For example, we see specific antibodies with I don't want to name anything. So I think it depends on the lab. But NXP2 can have, I've seen typical cases with NXP2, so they don't always fit the typical presentation of dermatomyositis. Dr. Kang must have seen some weird skin rashes with NXP2.
Yeah, absolutely. So I don't know what you mean by negative skin biopsies, again, but you sometimes need multiple skin biopsies to be able to kind of detect those things. Again, I think it can be challenging. It's a challenging diagnosis to make.
Can DM cause edema around the vocal cords?
Not typically. It can cause difficulty swallowing and dysphonia, which means that people have difficulty talking. Their voice becomes very soft. But this is not typical. Usually it's at the end stages when there is muscle involvement, diffuse muscle involvement. It's not that common.
Why does the skin on my face feel like it needs to be exfoliated? What can be done about dark patches on the face? And can you have DM on your scalp? And if so, what can be done for that?
Yeah, so the discoloration on the skin, which we sometimes call it follicular dermatitis changes, where it can look dark, red, kind of patchy, discolored skin. That unfortunately is a common kind of damage that we see from the active skin rash that patients with dermatomyositis develop. There are many cosmetic treatments that people have used to try to improve the outcome. So unfortunately, none of these are covered through insurance. I think that's such unfortunate thing for many of our patients. As a dermatologist, that I see not only dermatomyositis, but other conditions that can really lead to kind of disfiguring skin changes that can really impact the quality of life in our patients. Many of these treatments are not available readily without having to pay out of pocket and things like that. So, but there are options that are available for kind of to improve the cosmetic outcome. But first and foremost, I would just want to make sure that your disease is really truly well controlled before you kind of, exploring the ways to improve the appearance of it. Can DM on your scalp? Yes, you can definitely have DM on your scalp. And the treatments are, again, similar kind of, ways that we use. Topicals, I would say, generally don't work in treating dermatomyositis. If you're having a lot of symptoms from involvement of your scalp, and depending on how much hair you have, the vehicles that you're using for topicals can be quite cumbersome for the patients. but topicals, in addition to systemic medications, can help with improve your symptoms of the scalp DM.
Is it true that I should avoid taking immune boosting supplements?
Yes.
We don't know what they are, and we don't know what they do.
Yeah.
All right. What level of cancer surveillance should be done for DM 1 year after diagnosis?
This is still not answered based on data. Is mostly what experts recommend. Definitely, we know that the risk of cancer is highest 3 years before and after the disease onset. So we do recommend annual, at least the first year when the patient is diagnosed, to get a full cancer screening. And then after that, it depends on the risk factors, depends on what antibody they have, sex, age, disease manifestations. But in general, the first 3 years could have mammogram, pap smear, at least have one colonoscopy during all this time, if a man, PSA, prostate digital exam. And then we do either pan CT, CT scan of the chest, belly up, and the abdomen, or a PET scan, which is more expensive, has more radiation, and doesn't always get approved by insurance.
Has it been found that there is a higher rate of osteoarthritis in people with DM as compared to people without DM?
I don't think that has been answered, but pregnant use of steroids, that can lead to a vascular necrosis, weight gain, and all of these things that then can lead to osteoarthritis. So maybe indirectly.
Despite stretching, massage, etc., my leg and feet muscles are tight and rope-like. Blood work is good, strength is decent, and I'm fairly active. However, at night, the pain interferes with sleep. I'm looking for suggestions for relief. Thanks.
I don't think that I have any specific recommendations. Good hydration, like things that, simple things. Make sure vitamin D levels are within normal levels. Avoiding stress. I don't have any specific.
Is it the sunlight, the dermatomyositis, or the hydroxychloroquine that is making me itch? Is there another less harmful drug that helps with chronic inflammation? And beyond taking medication, what are your recommendations to alleviate the inflammation? Sometimes they put three different questions in one thing. We just take them one at a time.
So that's there's a lot of I think different aspects to that question. So sun definitely is a known factor for triggering not just dermatomyositis, but other kind of sun-sensitive autoimmune conditions. And that's because the skin cells, the keratinocytes, are intimately involved in mediating some of the inflammatory pathways that are very important in driving dermatomyositis. So yes, the first part is yes, sun can definitely trigger the itching. If you're on hydroxychloroquine for your dermatomyositis, I hope that your doctor counseled you on the fact that up to 30% of the patients can develop a different type of rash or hypersensitivity reaction to hydroxychloroquine if you're using that to treat dermatomyositis. So yes, that can also lead to skin symptoms and skin side effects. And then the third part of that question was, are there less harmful medications that can be used? I think every drug has pros and cons, and we are always trying to find the least harmful medication for the patients. In terms of what is approved, or I shouldn't say approved, what is available readily for doctors to use to treat systemically to treat dermatomyositis, specifically speaking, skin disease. Probably hydroxychloroquine is going to be one of the lesser harmful medications that we can give in terms of requiring less monitoring, less immunosuppressive, and things like that. There are other clinical trials that are being, occurring, things like cannabinoid receptor antagonists that has shown benefit in the skin disease, but not necessarily in the muscle disease. So, and I don't know where that's going. I don't think that medication, unfortunately, is going to get approved due to the lack of efficacy in looking at the overall skin and muscle and things like that. So in IVIG, that's why we commonly use it, because it is not immunosuppressive and things like that. So.
But I have to say, and that is something that maybe the TMA can help. The problem is FDA defines dermatomyositis as a predominantly muscle disease. So for a medication to be approved for dermatomyositis, it needs to be effective for the muscle predominantly. So that's why the cannabinoid receptors were not get approved, because it didn't have much effect on the muscle. And we just need to convince FDA that we just need something for the skin. It doesn't have to be.
Okay, let's see, I'm just going through the questions. We have so many. Is stem cell treatment being done for DM in the States?
No, I think the short answer. There is some stem cell work done for scleroderma, which is a more aggressive disease, and we don't have much treatment available options, but not that I would recommend for dermatomyositis. I think the medications we
I mean, it probably the cons probably outweigh. I would say the pros of, I think there just isn't that much to add. I mean, we know that from small cases, people who end up getting transplant for cancer reasons and things like that, they will improve. That has been shown in some cases, but not the typical thing that we look for, I would say.
How would we stop and revert calcinosis?
Oh, wait. Dr. Tiniakou. That's a really challenging one. We generally think that patients suffering from severe, long-lasting disease, patients with NXP2 antibody, are at higher risk of developing calcinosis, and you will see even subclinical calcinosis. That's something that I'm actively trying to understand, is at least from the skin perspective, like what is going on, why is this happening? There are some small studies showing certain medications might be better at improving the symptoms of calcinosis. But really, the first thing is making sure your dermatomyositis is really well controlled with the right medication. I would say that is the most important thing. Avoiding trauma.
As someone who is almost 4 years into a TIF1 DM diagnosis that has become a highly refractory skin predominant disease, are there any new medications being looked at or research trials in process that are skin focused, as the trials I have looked into seem to require muscle enzymes as the evaluation metric? Asking as I have failed both a range of immune suppressants, including JAK inhibitors and IVIG, and thankfully so far have no cancer.
This is something that I encounter oftentimes as I work with Dr. Tiniakou and other myositis experts. Type 1 interferon is a very well-known signature, especially in the skin, in the blood and the muscle of patients with dermatomyositis. And we are using more, again, off-label, using some of these medications to treat this. There are clinical trials going on trying to block type 1 interferon to treat the disease. And so far, I would say there's some promising results that are coming out. So hopefully there are newer and better medications that are coming out to especially help with some of the skin manifestations.
Thank you. This person has NXP2 antibodies and they were diagnosed 11 months ago, had a CAT scan of abdomen and pelvis, but it was without contrast 7 months ago. Asked their room about repeating the scan with contrast, but he didn't want to do another scan due to risk of exposure. Do you think it's okay to wait, or should I insist on contrast?
It's like 11 months. Yeah, I mean, it's
They've had the diagnosis 11 months. Their last CAT scan without contrast was 7 months ago.
yeah, that's I think it should be okay to wait. The contrast helps with specific, more like inflammation to recognize. I think it's okay to wait a few more months, as long as the patient has colonoscopy and all the other testing, CAT scan of the chest.
The neck, I mean, that's one of the recommendations they talk about, also including the neck and things like, because it can easily miss, the nasopharyngeal carcinoma and things like that too. So depending on, again, there's a lot of like caveats with everything, I think, just because I think depending on the patients, depending on the disease phenotype, what symptoms you're experiencing can be very heterogeneous. So not one specific answer, I would say.
Define the criteria that determines a DM diagnosis is cancer related. How often is cancer found immediately before or after a DM diagnosis?
So cancer-associated myositis, defined if the cancer is diagnosed within 3 years of dermatomyositis. So that is 3 to 5 years. The strict definition is 3 years, but we do see that it might be going up to 5 years. So what was the other part of the question?
How often is cancer found immediately before or after the diagnosis?
I think it depends on the antibody. Mostly, the risk is higher for dermatomyositis. Can be like 2-3 times more often than the general population, but I don't have the exact numbers on my head. I don't know if John, you know.
I think with the TIP1 gamma, it was quite high, right? I think the odds ratio was like 10, I want to say, right? And then for things like NXP2, it was more moderate, 2-3 times. And then there's certain, autoantibodies where it's not that significantly elevated compared to, especially if you're comparing it to like TIP1 gamma and XP2 and things like that. And Dr. Tiniakou has mentioned usually the highest in the first year, and then certainly up to 3 and even up to 5 years. But
yeah, so it depends on for us, like predominantly it's the antibody.
Is there a way to prevent a flare-up? And if it can't be prevented, what do you recommend to help minimize the flare and inflammation?
I think, as Dr. Kang said before, avoiding the sun can be one way to avoid the flare. Then
Stress, eating right.
Stress definitely increases the risk of flare, not only for dermatomyositis, for autoimmunity in general. We do see that stress can increase the risk of flare. Infections, big events like surgeries could lead to a flare, but I don't think that, we have a way of controlling when a flare shows up.
This person's been diagnosed with DM, but some of their symptoms fit more with IBM or PM. How can I really know which one is it?
I mean, the IBM diagnosis is mostly clinical. That it's a difficult one to make. It depends on the symptoms, but both PM and IBM do not have any skin involvement. But there could be an overlap, although I've never seen an overlap with IBM of dermatomyositis.
Right, that'd be kind of unusual. Yeah.
How would you follow a patient who is consistently showing a weak positive PL12 and high RO52 autoantibodies?
So these ones present predominantly with lung disease, and especially with the addition of RO, the risk of a severe lung disease is higher. I'm assuming to have a positive PL12, there must have been checked. There must be a reason why it was checked, but in general, for PL12 patients, I would monitor them with PFT, do a baseline chest CT, and then regular PFTs. And the frequency depends on the symptoms and the other elements, but.
This person was told the muscle in their neck became fat. Can they improve their neck muscle weakness through physiotherapy?
So once part of the muscle becomes fatty tissue, you cannot get it back, unfortunately. But what you can do is work with physical therapy to strengthen the healthy muscle that is left over so that it can compensate for what is lost. Sometimes if the loss of muscle is significant, people might not be able to get back to their baseline, but definitely with physical therapy, you can. The goal is to try to get as strong as you can.
The rheumatologist who found that I had the NXP2 antibody moved, and I currently do not have a specialist. What type of specialist do I need to request from my family doctor for a referral for a muscle biopsy to confirm?
It depends on where, it depends on the place, but neurosurgeons and neurologists in general are doing the biopsies. In some places, general surgeons as well, but it depends on how they practice at that place.
Hey, this person is a myopathic, diagnosed 2 years ago, has been on IVIG over a year. All symptoms has subsided a year ago and still growing hair out. Wondering how much longer I have to be getting infusions. If my doctor does say I can taper, how does one taper?
I think there is no right or wrong answer. I assume you said amyopathic, mostly skin.
Did I hear amyopathic or myopathic?
Myopathic.
Okay. And the question is, their hair is not growing out. They're doing
The
well.
hair is growing out. They're doing well. Symptoms subsided. It
Yeah.
seems like they want to stop getting infusions and
Yeah.
they want to taper, but they're not sure what that might look like.
I don't think there's a right or wrong answer. It's really, I try to really use shared decision when it comes to this. And again, a lot of things that I do as a dermatologist is quality of life. And because these are relatively rare diseases, we don't have like robust data to say, okay, now you are symptom-free for 6 months. Now we can stop medications. There's no such data that I know of. What I do see is when we do stop the treatment, a lot of my patients do flare one way or the other. So I do taper IVIG for sure. We can certainly try every 6 weeks, every 8 weeks, and you can slowly taper that over the next few months every time going down on it to see whether your symptoms are remaining well controlled, stabilized, and not returning. And at a certain point, I think you're going to have to, if you're doing every 2-3 months of IVIG, not having any symptoms, and now it's been 6 months. At that point, I guess one could ask, well, is IVIG really even doing anything at that point? Just because IVIG does tend to go away its effect after about a month or so. I think, again, that's a discussion that you have with the provider that you're seeing to see how you want to go about monitoring and things like that. So.
From my experience, I've had patients that stopped everything without telling me, and their symptoms never came back. And I have patients that I were on maximum dose of Sunset. I cut down by only 1 pill, and they flared. So I think
Right.
we don't know.
Yeah.
Oh,
And that's something that I think other people, researchers are looking into, biomarkers, right? So like, even when clinically they look really well, do we have subclinical inflammation, right? So from the blood and things like that. So I know this is kind of sometimes discouraging, I think, for patients to hear when we don't have the answers, but do know that people in the field are looking into this and trying to figure out so that we can better guide you and things like that. So
what treatments are available for hair loss with DM?
yeah, that's, again, when I see patients with hair loss as part of their disease manifestations, that means their disease is not well controlled. So it's really going to be globally looking at what symptoms are they having, what are they suffering from, what are the objective markers, are their muscles really elevated, how are their lungs doing? So really everything in context. Or is it that you just went through something serious illness, you were in the hospital, because of your dermatomyositis flare, and then several months later, you're really shedding, which is a little bit different than having hair loss as part of the disease manifestations of dermatomyositis. That means it's a stress response where your body's hair follicles are going into this telogen phase where everything kind of shifts into one gear and they start to fall out. Eventually, assuming again you're feeling better, doing better, your disease is better controlled, that will come back. But if it's a part of your disease manifestation, we're again looking at globally, how is your DM doing? How do we best manage that?
This person is an RN working as a nurse and patient at a large hospital. They see patients with all kinds of isolation precautions and antibiotic resistant bacterial infections. They are on the treatment of steroids, methotrexate, and Rituxan infusion, and wanting to know if, in your opinion, the PPE that they wear while they're working is keeping them safe enough.
I think all these precautions are to avoid getting infections, no matter what, if you're immunosuppressed or not. So I think it should be enough. Of course, if they get infected, the risk is higher to have more severe disease. And
Go ahead.
also, and I have to say, if this is very stressful for the patient, again, like stress can make the disease worse. So I do recommend patients to do things that they don't make them that anxious, if possible.
Right.
Yeah. I've worked with nurses in this situation where they had the luxury of, I think, requesting different type of jobs because they were really stressed about the fact that I'm giving them all this medication and they are having to, be exposed to this, even, especially during COVID era and things like that. So if you have the luxury, that's something you can certainly request and work with your employers and see and things like that. And I've certainly written letters for my patients trying to justify why this might be a reasonable thing. So
Has any research been done regarding seasonal changes like summer to fall, winter to spring, triggering DM flares? It seems like that's when my disease is most active.
I am not for, as far as I know, not for flaring, but we have seen that some specific autoantibodies, they do appear seasonally, like MDA5 and SRP. And we recently were trying to do a study to see if there is some infection. And it seems that specific virus might be associated with specific types of myositis. But I do not have any data about flares.
something that I see for skin diseases, sun exposure. My dermato patients, my lupus patients who are exquisitely sun sensitive, I think it just isn't possible. You just get more sun exposure during the summertime, whether how much ever you're trying to minimize in wearing sunscreen and things like that. So I've seen that specifically, yeah.
Can DM come with neuropsychiatric symptoms? And is this alleviated with immunosuppressant treatment?
I think neuropsychiatric is a very broad term. It depends. We don't see specifically DM affecting the nervous system, but what we can see is dysautonomia, as we said at the beginning, which is dysfunction of the autoimmune nervous system, and people can have many different symptoms like brain fog and muscle pains, difficulty standing up from a sitting position that have to do with the nervous system, which is typical what we see after COVID infection, the post-COVID syndrome. We can see that in patients with myositis, but dermatomyositis itself affecting directly the immune system, like the nervous system, like lupus, that we have not seen. So the question is if the patient has some overlap with something else.
Okay, and my final question for both of you as we wrap up this webinar on DM, when you have someone, a patient in your office and they are obviously scared and stressed about this diagnosis, do you have any words of comfort that you share with them that you can share with our audience now? I'm sorry to surprise you with that. In the future, I will tell people I'm going to spring that question on them, but I have a feeling that you guys have great bedside manner.
My advice is day by day. It's a disease that we do have medications to treat, and our goal is always to, we're trying to get the patient back to their baseline, to how they were before. It might be a long process, but it might be a shorter one, but day by day, not stress about the future, and we will be working with the patient to get them back.
Yeah, I echo a similar sentiment. I tell my patients that really I'm here to really improve the quality of their lives, and yes, this condition is associated with many scary conditions, but we know what we're dealing with, and we are here to kind of help them work that up, and plug in with the right team of doctors who are, if you need pulmonologists and things like that, to really, I don't want my patients to feel like there's no hope, right? Because when there's no hope, I think that's when things start to really look bleak, I think. And I try to really instill in my patients that there is hope, that we have treatments, we have options. So I try to really stay hopeful for my patients. So, yeah.
That is wonderful. Thank you both for the critical work you do for the myositis community. Thank you for participating in this webinar. We really enjoyed having access to your expertise. And thank you in the audience for watching our webinar. Be sure to catch our next Ask the Doc, because it will be on December 3rd at 3:30 p.m. Eastern with Dr. Adam Schippenbauer, and we will be able to answer questions about any myositis type. That one will not be recorded. So if you want to ask Dr. Schippenbauer a question, you will need to be present and live. We'd also like to give you a special invitation to attend our monthly support and affinity groups. Research has shown that people who receive support from a social network cope better, feel more in control, and have better outcomes than those who are isolated. So please go to our events calendar on our website and register. And again, thank you so much for TMA. I'm Rachel Bromley. Enjoy the rest of your day.
Thank you for having me.
Thank you.